About assessing patients who collapse. Now this can be an extremely daunting prospect because the slides move on. There are so many possible causes. So as I say, I'd just like to echo Professor Ralston's welcome. It's very good to be here, and I do hope that we'll speak to you after this lecture and hear your thoughts about things and in any way that we can improve it, particularly for your needs here in India. Very helpful. So I'm going to speak to you about collapse, query cause. Now, assessing a patient who's collapsed can be a very daunting prospect because there are so many possible causes of collapse, and you look at that list and your heart sinks. What this means is that your assessment has to be extremely well structured to identify the most likely causes and therefore the most appropriate investigations as quickly as possible. So the aim of this talk is to give you such a structure. I'm going to divide the talk into three sections to cover the different contexts in which patients who collapsed may present. First of all, they may present still unconscious following their collapse. Secondly, you may be assessing the patient after a self-limiting episode of loss of consciousness. And finally, and possibly most difficult, is assessing the patient who's collapsed but without losing consciousness. So I'm going to start first with the unconscious patient. Now, clearly they need a very rapid assessment, and it's useful to keep the broad categories of cause at the front of your mind when you're looking at the patient. And these categories are neurological, toxic, and metabolic. So neurological causes might include seizure, subarachnoid hemorrhage, stroke, head injury, or meningoencephalitis. Toxic causes, certainly in the UK, we would think about alcohol, opiate, or benzodiazepine, often misuse, but also a deliberate overdose. In the case of tricyclic antidepressants, it's almost always a deliberate overdose. I appreciate maybe very different toxins that you also would consider in that list in India, perhaps including snakebite and possibly other poisons, organophosphates. I'd be interested to hear what you can tell me afterwards. Metabolic causes include hypoglycemia, certainly in the UK hypothermia. I don't know if that would be an issue in this climate. Severe hypoxia, liver failure, and electrolyte abnormalities too can cause coma, though the patient may be more drowsy depending on the severity of these. So how do you go about assessing this unconscious patient? Well, clearly, unless it's due to a head injury, this is a medical emergency, and a lot has to happen in a very short space of time, hence this rather busy slide. The first step is ABCD, which would be to check that the airway and breathing, the circulation are secure. You then want to check the BM sticks. You want to take blood for full blood count, blood chemistry, toxicology screen, blood cultures may be relevant, blood gases, and you want to obtain a 12-lead ECG and establish a monitor. If the BM6 is very low, clearly you want to give intravenous dextrose immediately. You then want to go on and check for focal neurological signs. You may ask, how do you do that in an unconscious patient? Well, you should look at their pupils to assess their symmetry and size, look for any abnormal eye movements, check the motor response to pain, and check the plantar responses. If you find any signs, or if the patient has meningism, fever, and particularly if they also have a rash, they will need intravenous antibiotics immediately. In the UK, we would use ceftriaxone to cover the most likely organisms in our country. You also want to look for signs of opiate overdose. Has the patient got pinpoint pupils? Have they got respiratory depression? Have they got signs of track marks from regular misuse? If any of those signs are present, you give IV naloxone at once to reverse it. If there are no obvious pointers at this stage, it's very useful to take a history from a witness or a family member? Was the patient unwell before they collapsed? Did they complain of headache, or did they seem confused? Was there any sign of a seizure at the time of their collapse? Do they have a past history of epilepsy, or diabetes, or depression? Were there empty packets found at the scene of medication, or even a suicide note? If you're still not sure, you have to widen the search further. We would think of hypothermia and check a core temperature in case the patient needed rewarming. We would also look for jaundice in case they had liver failure. But often you still have no clues, and at that point you have to think about a CT scan of the head. But you must make sure before putting the patient in the scanner that their airway, breathing and circulation are secure. If the CT head is normal, you then consider going on to a lumbar puncture to look for subarachnoid hemorrhage or meningitis. Categories that patients come under here. They may have had an episode of cardiac syncope. They may have had a neurally mediated syncope, by which I mean the autonomic system was responsible. And finally, perhaps less commonly, seizure has to be considered. And other causes such as narcolepsy, non-epileptic attacks, and panic attacks are much rarer, much rarer. So the types of conditions to think about under each of those categories are as follows. Cardiac syncope can be caused by structural heart disease or dysrhythmias. Neurally mediated syncope can be caused by a whole variety of syndromes, a vasovagal episode, carotid sinus syndrome, orthostatic or postural hypotension, and the situational syncopes such as cough, defecation syncopes, Valsalva-induced syncope. Similarly, the strangest one I saw of that was a man who passed out while trying to play a trumpet. He was a beginner, I hasten to add. And finally, postprandial syncope should be thought of. Seizures may be provoked. They may be due to a primary epilepsy syndrome or secondary to a structural abnormality. And I'm just going to speak about the assessment of each of these in a little more detail. The first step you have to consider is obviously trying to differentiate between the different three causes. Was this cardiac, neurally mediated, or a seizure? And the most important thing is the history, and a witness account is absolutely essential. There are four characteristic pieces of history that you need to concentrate on. The first is, what triggered the attack? Now, in a cardiac event, it may have occurred on exertion, but very often occurs with no trigger at all. On the other hand, the neurally mediated syncopes have very characteristic triggers for each of the different syndromes. And I'm going to come back to these later, but they can include prolonged standing, postural change, head movement, or prolonged coughing. Seizures, again, may have no obvious triggers, but they can be provoked by sleep deprivation, alcohol or drug excess or misuse, and occasionally flickering lights such as strobes or even TVs or PC monitors. The second important feature in history are the warning symptoms. Now, in cardiac syncope, many patients have no warning whatsoever. They just black out suddenly. But some people may describe preceding lightheadedness, palpitation, chest pains, or breathlessness. On the other hand, neurally mediated syncope is almost always have associated warning symptoms. And they particularly include nausea, lightheadedness, blurred vision, and sweating. Seizure, again, there may be no warning, but some patients describe an aura, and this can be often quite an unusual history where they describe a disturbance of memory, such as déjà vu or jamais vu. They may have a sudden sense of fear. They may have a very unpleasant taste or smell, or may have difficulty speaking. Witnesses may describe them appearing confused just before the event. The third feature to particularly ask about is what happened during the unconscious period. Pallor is the absolute rule in syncope. Patients go completely white, and often witnesses think that they've actually died. In a seizure, a witness will describe rhythmic twitching or jerking of the limbs, but you should be aware that occasionally in syncope If cerebral anoxia is very prolonged, you may see a few twitches and jerks there as well, which can be very confusing. Tongue biting is a very useful piece of history. That would never occur in syncope and is very specific to a seizure. Urinary incontinence is less useful in that it can occur occasionally in syncope, so it isn't a good discriminator between syncope and seizure. The fourth feature to ask about is the recovery period. In cardiac syncope, this will be extremely rapid and sometimes associated with flushing. The patient will feel fine very quickly on recovery. In neurally mediated syncope, it takes a little longer, perhaps 1 or 2 minutes for the patient to come round. But they may feel a little nauseated and lightheadedness for several hours, but otherwise the recovery to consciousness is very rapid. Now this contrasts with seizure, where the recovery period is much longer. And a very useful tip here is to ask the patient what they remember first when they awoke. Those that had syncope will remember waking up on the floor where they collapsed, whereas those with seizure may not remember anything until they're in an ambulance or in the emergency room. That's their first memory of awakening. They can often appear confused when they first awaken. They may have headache. Myalgia is a very good discriminator, which you wouldn't see in syncope. And they're often, as I say, confused and drowsy for some hours later. You may also find focal neurological signs during that recovery phase, which you would never see, obviously, after a syncopal episode. So having established which of the categories that the patient is most likely to come under, you then have to think about specific causes. It's useful, perhaps, first of all, just to look at the different causes or categories by age. And as you can see here, the neurally mediated syncopes in white are much, much more common than the cardiac structural disease or the arrhythmias, even in the elderly, where they're most common. So most patients will have had a neurally mediated event rather than a cardiac event. Despite that, you should always look for cardiac disease. And the reason for this is that syncope caused by a cardiac problem carries a significant mortality, which clearly you want to prevent. So looking more specifically at the cardiac causes, as I say, first of all, structural disease has to be considered. And these you can look at in two ways. First of all, those events that cause outflow obstruction. That would include severe aortic stenosis, hypertrophic obstructive cardiomyopathy, or very occasionally a patient may collapse as a result of a pulmonary embolism. Now on the right-hand side of the slide there, you can see a 2D echo demonstrating the failure of opening of the cusps of the aortic valve during systole compared to a normal aortic valve. Severe coronary artery disease can also cause collapse, particularly during exertion, because of failure to increase cardiac output in response to metabolic need. So again, that has to be considered. Say the other category of cause would be an arrhythmia. And there's really only a limited range of arrhythmias that will result in syncope as opposed to dizziness. And these are the profound bradycardias and malignant ventricular tachycardia. So first of all, here we have an ECG showing the most likely causes of those bradycardias. First of all, sinoatrial disease, which can be associated with profound sinus bradycardias or sinus arrest. And interestingly, the atrial fibrillation that you may see in sinoatrial disease doesn't tend to cause and collapse, more simply in dizziness. Complete heart block, we have the ECG here showing P waves which are not conducted, and a very slow ventricular escape rhythm underlying that.